the presentation is about the present and also the future. Tanja Golli, the doctor from Pediatric Clinic, University Medical Center Ljubljana, of course from Slovenia, will present us the maybe new achievements which is necessary to think about the treatment patients with Duchenne disease. Welcome.
Okay, so my presentation will be actually on the treatments of Duchenne. Now, we've heard a very detailed talk on the future on gene therapies, but really what I'm going to focus on will be the non-genetic type of treatments that we have available now and what might be in the future for patients with Duchenne. Now, this first slide, just a quick reminder of what we're talking about. We have the dystrophin gene here and the picture below, the dystrophin protein, which is part of the glycoprotein complex in the cell membrane. And when this isn't working properly, then the membrane can't function properly. And this leads to buildup of calcium in the muscle cell. It then degenerates, which will activate satellite cells, which will activate inflammation, regeneration, and fibrosis, and also other pathways such as the nitric oxidase synthase activity. And this in turn also impairs blood flow. And what this results in is, of course, the typical phenotype that we associate with Duchenne, with the involvement of the skeletal muscle, the heart, and the respiratory system. And also because of the expression of different isoforms outside of muscle cells, we have the other manifestations that we can associate with Duchenne, like the cognitive parts of defects in this disease. Now, if we go to what we can offer patients at the moment, I think it's very important to stress that we do have very good current standards of care. This is the last version that was published in Lancet Neurology in 2018, and it's a process that is being reevaluated as we go along, because different things start to show, and there's different therapeutic measures that we can offer patients. But the basis of these standards of care is the fact that we are dealing in essence with the multi-organ disease. So there are different organs that are involved in the there are different organs that are involved in this disease, and this is why we need a multidisciplinary approach to the treatment and follow-up of these patients, and it's something that I think in most countries is functioning quite well. Of course, it's the neurologist who has the basic, function of diagnosing these patients and then following them and communicating with different other specialists, especially the respiratory specialists, the pulmonologists, who will follow the patients as pertains to their respiratory function. We have the cardiologists, also a very important part of this multidisciplinary team, because we know that cardiomyopathy and heart failure are one of the major causes of premature death in patients with Duchenne. We have the orthopedic surgeons who will help us with manifestations such as scoliosis and contractures that will eventually ensue in patients when they lose ambulation, when muscle weakness in different muscle groups ensues. We have the physical therapists and the physical physiatrists who will help with retaining ambulation, retaining muscle function as long as they can, with helping with orthosis and other devices to help ambulation in patients. Also, bone health is a major part of taking care of these patients, because we know as the muscle weakens, as ambulation is lost, then bone health will degrade. And of course, we have to address this as well. Usually it's the endocrinologist who will work with patients on this aspect, and also the endocrinologist will follow them as far as certain hormonal manifestations that might also ensue. They follow the growth that might be retarded because of the disease itself, but more often because of the treatments that we actually offer these patients. And then, of course, a very important part of this multidisciplinary team are the psychologists, because we have a very large psychological impact on the patients with the disease. It's chronic, it's progressive, and the impact is also on the family, on other family members. And we have all the other types of specialists that help us communicate, let's say, with primary care physicians, with schools, with different other organisms might help the patients to improve the quality of life and the longevity in these patients with Duchenne. If we go forward and talk about the current medications, the drugs that are available, the mainstay, of course, of treatment at this moment are steroids. We usually use prednisolone or deflazacort, and this was a major breakthrough when it was started. As you can see on the right-hand side, the diagram with the two arrows, this is a presentation of how steroids have changed the progression of the disease. And what you can see is that actually they impact loss of ambulation, they impact respiratory function, and what happens is that we delay the process of the disease. We can't cure it, but with steroids we do delay the progression, and they lose ambulation later, and the respiratory function is also retained longer. And of course, the heart muscle is also to some degree protected by the steroids. The second group of treatments that are also available are the heart protection treatments. Now we know that the heart muscle is also involved in Duchenne, and there are quite a few drugs that are used not only for Duchenne and cardiomyopathy, but these are drugs that are used in heart failure from other diseases. And actually they have shown a cardioprotective function, the AC inhibitors, the ones that we institute early, and all the rest as treatments when cardiomyopathy or heart failure ensues. As I talked about earlier, bone health, also a very important part of treatments in Duchenne. We use calcium, vitamin D, biphosphonates to strengthen the bones, and also endocrinologists will treat with testosterone or growth hormone when that is specifically needed in a patient. There are two groups of specific treatments that are available in clinical use at the moment. Not in all countries, but let's say in most countries in Europe. And those are the nonsense skipping Ateluran drug and the exon skipping group that I saw that you heard a lot about earlier in the previous talk. The treatment approaches that are being looked at for the future are, of course, mostly targeted on dystrophin restoration, and we've heard quite a lot about it in the previous lecture. But also other areas of research to improve the treatments and quality of life in patients. They're not actually curing the disease, but they are improving life and life expectancy. So these are the drugs that are trying to improve heart function. Also the area of reducing inflammation, similar to steroids. Myostatin and Antifibrotics targeting also inflammation and fibrosis. The Eutrophine modulators, also a group that is being researched. And last but not least, the Nutraceuticals, which I'll talk about for just a little bit in the future. As far as improving heart function goes, as I mentioned earlier, heart failure is the major cause of early death in patients with Duchenne, and steroids have to some degree changed this, protecting to some degree the degeneration of heart muscle. Also, it has been shown that early installation of cardioprotective medicines such as AC inhibitors will lessen the progression of cardiomyopathy. And then, of course, early diagnosis and treatment of heart failure also improves the quality of life and the longevity in these patients. But still, we cannot undo actually the process of the disease, and it is a progressive failure of the heart that will ensue in all patients with Duchenne sooner or later. There are some drugs being evaluated, and one of these is the CAP 1002, which is in phase 2 of clinical trials in the USA. And basically what it is a cardiac cell therapy, an allogeneic cardiac cell therapy with cells derived from donor hearts, healthy donors, and they can be infused directly into the coronary arteries. And the theory is that they will actually spread through the muscle, acting maybe as a form of stem cell or a form of a messenger for the heart cells of the patient to work better, to regenerate better. And this is still in phase 2 trials, but it is showing promise that we might be able to improve the heart function with these types of treatments in the future. Reducing inflammation is also a very important part that is being researched. As I said earlier, steroids are one of the treatments that have shown us a great advantage in the past. But of course, the problem is that they also have significant side effects. They can affect growth, delay puberty, weaken bone. So some patients have very severe side effects, and this precludes them from getting the drugs in the doses that would be effective on the muscles. So one of the areas of research are new steroids that would, have the same protective effect on a muscle, but on the other hand, will not have as many side effects. And one of these is valmorolone, which is in phase 3, actually, clinical studies, and it's being promised that it might actually be in clinical use in the next year. So we're hoping that this will, of course, be possible for our patients, because we try to have all patients on steroids, and if this is a better one, then of course we'll be switching to this treatment. There are also other anti-inflammatory drugs or substances that are being researched to possibly lessen the inflammation that ensues in muscles in Duchenne, but also in other muscle diseases. So this is not something that is necessarily just for Duchenne. It might be for other muscle degeneration diseases. One of these is this NF-κB inhibitor. It's not a steroid, but it is something that is present in inflammation in Duchenne and other skeletal muscle disorders. And they're in phase 2 studies. They're trying to see if this inhibition of this molecule will actually reduce the inflammation and reduce the muscle degeneration and improve muscle strength and function. Some other substances also that might possibly target inflammation, such as tamoxifen, IVIG, are also being looked into, but not currently in clinical trials, except for tamoxifen, which I'll talk about later. Myostatin inhibition, also an area that looks at inflammation, degeneration, fibrosis of muscle. Myostatins actually are growth factors, part of the TGF-beta family, and actually myostatin will inhibit muscle growth. So the logic is that if you inhibit myostatin, then you might be able to increase muscle mass, muscle strength, you prevent the degeneration of muscle, wasting of muscle, and thus you prevent what happens in Duchenne. And there have actually been 6 trials of different myostatin inhibitors in different muscular dystrophies. 3 of these trials have been actually in pediatric Duchenne patients. And they have in general demonstrated that it is a safe mode of intervention. But unfortunately, the clinical effect was not what we were hoping for. So really at the moment, they haven't thrown them out as a treatment yet. But it's most likely that it can't be modified to use it as a monotherapy in Duchenne or in other skeletal muscle diseases. But it might be part of, let's say, a cocktail, a combination of therapies that might improve muscle strength. The antifibrotics. Now, as I said earlier, you have, once you have a defective dystrophin, you have a destabilization of the glycoprotein complex. And then, of course, you have the degeneration of cells, so tissue damage. The repair is then incomplete. And some of the muscle fibers will degenerate and they're replaced by fibrotic scar tissue, and this then leads, of course, to muscle loss and muscle weakness. And again, okay, I hope you can hear me again, because I seem to have lost the connection. But as I said, the basis of this is if you can influence this TGF-beta pathway, then you can inhibit fibrosis, lessen muscle loss and fibrotic scar tissue formation, and thus improve the muscle health. The other area also being researched here are the microRNAs. Now, microRNAs are small non-coding RNA molecules that are naturally expressed in different organs, in different tissues, and what they actually do is they regulate gene expression. And it has been seen that certain microRNAs are expressed more often in involved fibrotic tissues. And if we could in some way impact which microRNAs are expressed in different tissues, we might actually be able to decrease fibrosis and again lessen the effect of muscle scarring and muscle loss. Another group of molecules that is also being researched are the eutrophine modulators. Eutrophine actually is a protein that is found naturally in muscle in small quantities, and its function is actually quite similar to dystrophine. And if there was some way that we could upregulate the expression of eutrophine, we might actually be able to replace the loss of dystrophine that is the integral part of Duchenne. And there are some molecules that have been in phase 2 clinical studies but were discontinued either because they weren't effective or there were some safety issues. One of these new ones is being prepared for human clinical testing, and this is the biglycan molecule. And it doesn't impact only upregulation of eutrophine, but it also acts on other dystrophin-associated proteins and pathways, the MuSK kinase, the nitric oxide synthase pathway. And in this way, it might be able to impact, again, muscle strength and lessen the effects of the abnormal dystrophin in Duchenne. This slide is just showing you some drugs that we actually count as repurposing drugs. So these are drugs that have been in use for other diseases, but have shown some promise in also affecting, targeting what is wrong in Duchenne. The first three of these, like tamoxifen, it was something that was used in breast cancer in the 80s. And it has been seen to possibly reduce fibrosis and inflammation in muscle, and thus it's being looked at whether it might delay disease progression in Duchenne. Metformin, also a drug that has been used for a different indication, that's diabetes type 2, and it seems to influence the nitric oxide synthase pathway, and thus it might actually improve muscle health. Givinostat is also a substance that is being researched. This is now in phase 3, not a repurposing drug as such, but it also impacts the nitric oxide synthase pathway, and thus it impacts inflammation and blood flow in the muscle. The third repurposing drug, the ramipride, it's a drug that was first developed for treating congestive heart failure, but it is now being looked at maybe as having cardioprotective efficacy also in patients with Duchenne. Still in phase 2 clinical studies, so we don't have all the information as to its efficacy yet. Nutraceuticals is an area that might sound a little sci-fi, but actually what we see is that most patients will be trying under the counter, let's say, or self-imposed diets. And the basis of nutraceuticals is that actually some food sources, some substances in regular food might have anti-inflammatory and antioxidative effects. And all of these substances that I wrote down here have been stipulated to have effect on inflammation in muscle, but only in animal studies.
We have some technical problems with connections. I also was interrupted in some way. That's why I switched automatically in Polish. I'm sorry for that. I'm waiting for the information from technical support if we can have the connection. If not, we almost on time. If it's like that, that probably will not back. It's a really pity. The presentation about the future, especially in Duchenne disease, was, I think, prospective and giving the chances that based on the previous experiences in the system in different countries, the Duchenne disease could be built in better way and maybe the faster to have better access for patients, not only for therapy, but also for multidisciplinary care.